Abdomen, surface anatomy, anterior abdominal wall. Boundaries of the abdominal cavity. The anterior abdominal wall is bounded superiorly by the costal margin and the xiphoid process. It is bounded inferiorly from medial to lateral by the pubic symphysis, the pubic crest, and the pubic tubercle, the inguinal ligament, the anterior superior iliac spine, and the iliac crest. The abdominal cavity extends upwards behind the lower ribs under the diaphragm, and downwards into the pelvis to the pelvic diaphragm. Anterior abdominal wall. The anterior abdominal wall comprises 3 lateral flat sheet-like muscles. They fuse medially to form a fibrous sheath for the vertically running rectus abdominis muscles. The lateral line of formation of the rectus sheath is known as the linea semilunaris. The 2 rectus sheaths meet in the midline as a fibrous raphe, known as the linea alba. The 3 transverse lines of attachment of the rectus abdominis muscle to the anterior sheath can be seen in a muscular subject above the umbilicus. These 3 transverse lines of attachment are called tendinous intersections. Four abdominal quadrants. The abdomen can be divided into 4 quadrants by a vertical median plane and a horizontal transumbilical plane. The transumbilical plane passes through the umbilicus and the 4th lumbar vertebrae. The median plane passes through the xiphoid process and the pubic symphysis. The 4 quadrants here are called the right lower quadrant, the right upper quadrant, the left lower quadrant, and the left upper quadrant. The liver and the gallbladder are in the right upper quadrant. The stomach and the spleen are located in the left upper quadrant. The cecum and the appendix are in the right lower quadrant, and the distal end of the descending colon and sigmoid colon are in the left lower quadrant. 9 abdominal regions. The abdomen can be divided into 9 regions by 2 horizontal lines and 2 vertical lines. The midclavicular lines passes through the midpoint of the clavicle, the tip of the 9th costal cartilage, the deep inguinal ring, the mid-inguinal point, and the femoral artery pulse. The transpyloric plane is clinically more relevant than the subcostal plane. The transpyloric plane passes through the tip of the 9th costal cartilage and the body of the 1st lumbar vertebrae. The transtubercular plane passes through the iliac tubercles and the 5th lumbar vertebrae. These planes separate the abdomen into 3 central regions, also known as the epigastrium, the umbilical, and the suprapubic. The planes also separate the abdomen into 3 regions on each side: the hypochondrium, the lumbar, and the inguinal. In the epigastrium region, pain from foregut structures are usually referred to this area. The pulsating aorta is palpable to the left of the midline. Stomach tumors may be palpable here. Umbilical region. Pain from midgut structures is usually referred to this area. The pulsating aorta is palpable above the umbilicus. Suprapubic region. Pain from hindgut structures is usually referred to this area. Enlarged pelvic organs may be palpable here, for example, the uterus and bladder. Abdominal organs. The liver. The liver lies in the right hypochondrium above the costal margin. The upper border of the right lobe of the liver bulges into the diaphragm and is at the level of the fourth intercostal space. The fourth intercostal space corresponds to the nipple in a lean male. The left lobe of the liver passes deep to the xiphoid process across the epigastrium region. The gallbladder projects just below the liver at the point where the midclavicular line crosses the costal margin at the tip of the ninth costal cartilage. The spleen. The spleen is situated on the posterior abdominal wall in the left hypochondrium along the 9th, 10th, and the 11th ribs. It is anterior to the left costodiaphragmatic recess of the pleural cavity. The spleen does not normally extend anterior than the mid-axillary line and is therefore not palpable. If the spleen enlarges and is palpable at the left subcostal margin, it is approximately 3 times its normal size. It may enlarge further diagonally down towards the right iliac fossa. The kidneys. The kidneys lie on the posterior abdominal wall and are retroperitoneal. The kidneys project onto the back on either side of the midline and are related to the lower ribs. The left kidney is higher than the right and reaches as high as the 11th rib. The superior pole of the right kidney reaches only as high as the 12th rib. The hilar of the kidneys and the origin of the ureters are at the L1 vertebral level, the transpyloric plane. The ureters descend vertically anterior to the tips of the transverse process of the lower lumbar vertebrae and enters the pelvis. The important posterior relations of the kidney are the diaphragm and the costodiaphragmatic recess of the pleural cavities. An inexpertly performed renal biopsy or injection into the kidney may first enter the pleural cavity and cause a pneumothorax. Transpyloric plane of Addison. The transpyloric plane of Addison lies midway between the suprasternal notch and the pubic symphysis. It also lies midway between the xiphoid process and the umbilicus. With the subject lying supine and the neck flexed, the transpyloric plane of Addison can be found where the linea semilunaris cuts the costal margin at the tip of the 9th costal cartilage. The abdominal viscera that lie on the transpyloric plane of Addison include the following: the fundus of the gallbladder, the pylorus of the stomach, the second part of the duodenum, the neck of the pancreas, the formation of the portal vein, the origin of the superior mesenteric artery, the hilar of the kidneys. Anterior abdominal wall. Points. Murphy's point. Murphy's point refers to the surface marking for the fundus of the gallbladder. It lies at the tip of the 9th costal cartilage, where the midclavicular line and the transpyloric plane meet. McBurney's point. Draw a line from the umbilicus to the anterior superior iliac spine. a third of the way up from the anterior superior iliac spine, is McBurney's point. McBurney's point refers to the base of the appendix. It is also the point of maximum tenderness in appendicitis. Mid-inguinal point. The mid-inguinal point lies midway between the anterior superior iliac spine and the pubic symphysis. The deep ring lies superior to the mid-inguinal point. It is a defect in the transversalis fascia and is the internal opening of the inguinal canal. The femoral artery pulse lies inferior to the mid-inguinal point. Palpate the pubic tubercle. With the lower limb in the position as shown, palpate the pubic tubercle by tracing the adductor longus tendon upwards. Superficial inguinal ring. The superficial inguinal ring is an elongated triangular defect of the external oblique aponeurosis. It is the external opening of the inguinal canal. The base of the superficial inguinal ring is the pubic crest and lies between the pubic tubercle and pubic symphysis. The superficial ring is the site where inguinal hernias appear. The neck of the inguinal hernia is above and medial to the pubic tubercle. In contrast, the neck of a femoral hernia is below and lateral to the pubic tubercle. Abdominal incisions. The choice of incision for laparotomy depends on the area that needs to be exposed, the elective or emergency nature of the operation, and the personal preference. The midline incision. The midline incision implies a vertical incision through skin, subcutaneous fat, linea alba, and peritoneum. The incision is easy to perform and results in minimal blood loss due to the avascular nature of the linea alba. The incision can be made easily and provides excellent exposure of the abdomen. Extension when required can easily be made superiorly or inferiorly, providing access to the whole abdominal cavity, including the retroperitoneum. All these qualities make the midline approach especially suitable for emergency or exploratory surgery. The use of the midline incision should be restricted to operations in which unlimited access to the abdominal cavity is useful or necessary. The liver and the gallbladder may be approached through a subcostal or cocker incision. It provides good exposure for biliary surgery. Many segmental blood vessels and nerves are dissected, as well as the fibers of the external oblique, the transverse and rectus abdominis muscles. The gridiron or McBurney's incision. The appendix is approached through an oblique incision about 3 cm above and medial to the anterior superior iliac spine and follows the direction of the fibers of the external oblique muscle, segmental blood vessels and nerves, damaging as little as possible. This incision splits all 3 muscular layers parallel to the direction of their fibers. The bladder and the uterus can be approached through the transverse suprapubic, also known as the Pfannenstiel incision. It is often used for gynecological and obstetrics procedures. The skin, superficial fascia, and the anterior rectus sheath are divided in line with the incision. The rectus abdominis muscles are not adherent to the rectus sheath at this level and can be retracted laterally to expose the transversalis fascia and peritoneum. These structures are divided in line with the skin incision.